Welcome. I'm Dr. Bill Dixon, and I have the pleasure today of sharing a lecture with you on how to treat calcium below the knee. I would like to thank Dr. Craig Walker and all of the fine folks at NCVH for inviting me to participate in this digital education series. And I hope it is very informative, and I hope it helps you with your daily practice. I practice in Tallahassee with Southern Medical Group and Tallahassee Memorial Hospital. There's my disclosures. So when we're talking about below the knee disease, the presentation is not claudication. When we think PAD, many times we're thinking of claudication. Below the knee disease is very different. It's ischemic rest pain, it's wounds, it's ulcers, non-healing wounds, ultimately amputations. So it's a very different presentation than typical claudication from disease above the knee. So because the presentation is different, the disease state is somewhat different, the goals of therapy are different. We're not trying to get them to walk further, we're trying to heal their wounds. Many of these patients have resting pain, ischemia at rest. Ultimately, we want to prevent amputations. We know that amputations affect quality of life, affect mobility, and also negatively impact survival. So keep in mind the goals of therapy when you're working on below the knee disease. So in general, calcified vessels, no matter where they are more challenging to treat than non-calcified vessels. There's early elastic recoil, so you dilate it, it tends to recoil back down and you get residual stenosis. Because the vessels are calcified, it takes higher pressure to get the lumen open. And so higher pressure leads to an increased chance of dissection or perforation. And then as a result of recoil, there's lower primary and secondary patency rates. So in general, calcified vessels are more difficult to treat and more difficult to keep open long-term. Below the knee vessels have their own set of challenges. In general, these vessels are smaller, often 2 or 3 millimeters. So the vessels are smaller, it means a smaller lumen. Often there's diffuse disease. So instead of discrete focal lesions, which we can sometimes see in larger vessels, there's often very diffuse disease. In addition to calcium in the lumen, there's also calcium in the media, which makes the vessel itself less compliant and more difficult to dilate. And also, this is generally a no-stent area. If you get a significant dissection in the superficial femoral artery, we usually bail out stent, no problem. But we try to avoid stents in the below the knee vessels due to crush, fracture, and poor long-term patency. So we have less bailout options below the knee. So as I mentioned, recoil is a big problem below the knee. So in the frame here, you see a standard balloon angioplasty, and the initial angiogram looks great. Hey, we got the vessel open, really nice result. If you are patient and take another picture a few minutes later, you may see significant recoil. So studies have shown that almost 97% of vessels have at least some recoil, calcified vessels following balloon angioplasty. And a lot of these vessels will have up to a third luminal diameter of recoil, even 15 minutes after balloon angioplasty. This is due to medial calcification. This leads to stiffened arteries, vessel recoil, and ultimately restenosis long-term. So how do we get these vessels open below the knee? What you see on this slide is the most recent expert consensus statement from SCA and I. I've highlighted the important points. So at least in 2014, PTA or balloon angioplasty is the current standard for treatment of significant infrapopliteal disease or below the knee disease. There are other options available, which we're going to discuss, but at that time, they felt that given the increased cost of other modalities, and at that time, the lack of comparative data compared to balloon angioplasty, that balloon angioplasty should remain the initial endovascular therapy for most infrapopliteal disease. So how well does that work? How well does balloon angioplasty work? Well, acutely, there's a fairly high procedural success rate, and the wound healing rate is pretty good. And again, that's our goal. The short-term patency, however, is very low. It's only 40 to 50%. So about the same percentage require reintervention in the short term. So Dr. Schmidt and his group in 2010 showed that at 3 months, there was only a 31% patency following balloon angioplasty below the knee. There was a significant improvement in clinical outcome, however. So if you can get the vessel open and it stays open long enough, generally you can heal wounds, but there's a significant chance you're going to require reintervention. Another study in 2013 showed similar results with a 27% patency at 3 months. And they did have a significant improvement in wound healing. 68% actually completely healed their wounds, but these have a tendency potentially to come back because the vessels don't stay open long term. So one of the problems with calcified vessels is you can't get it open easily with standard balloon angioplasty. So when standard balloon angioplasty is not working, what do? Do we use higher pressure? Do we use a larger balloon? Well, you can use higher pressure, but often this leads to barotrauma and significant complications such as dissection. Or if you decide you want to use a larger balloon, then there are times where you could end up with a perforation. And again, bailout options below the knee are somewhat limited. So how do we decrease the complications? How do we decrease recoil? How do we improve long-term patency below the knee? Well, there are some alternative strategies that are collectively referred to as vessel prep. So again, our goal is to reduce barotrauma and complications, change the vessel compliance, which allows more complete balloon expansion and acute luminal gain. There are really two technical strategies for vessel prep. One is to disrupt or fracture the plaque, score it or crack it, so to speak. The other strategy is to debulk or modify that plaque. So we can sand it, we can drill it out, we can vaporize it. Both of these strategies are usually followed by standard balloon angioplasty once you've modified the vessel. So for plaque disruption, our options are focal force devices. These are balloons which have pressure points, which are usually a metal alloy, often referred to as atherotomes. This includes cutting balloons, scoring balloons, and the chocolate balloon. And then another modality is intravascular lithotripsy. So I'm going to go into these in a little more detail. So focal force balloons include cutting balloons, scoring balloons, and the chocolate balloon. And you see pictures of a cutting balloon at the top, the chocolate balloon at the bottom. The key is focal pressure points to help score or crack the calcium and allow these balloons to get the vessels open. There's advantage of this strategy. They're simple to use. They're similar to inflating a balloon. They're not as expensive as atherectomy devices. May have a lower complication rate than standard balloon angioplasty because we're cracking the plaque and hopefully requiring less pressure to get it open. But there's not a lot of data regarding the efficacy and long-term patency. An interesting modality is called intravascular lithotripsy. This is the Shockwave balloon. These balloons employ miniaturized lithotripsy emitters, which cause expanding and collapsing vapor bubbles, which create a burst of sonic pressure waves. These waves travel through the vessel and lead to an effective local pressure of approximately 50 atmospheres per pulse. So this is a localized field effect within the vessel, which fractures the calcium in situ, right there in the vessel wall. It's a simple device to use. It's an 014 wire. There's a minimal learning curve associated with it. And this therapy allows vessel expansion at low pressure, usually just 2 to 6 atmospheres, reducing the risk of barotrauma and the need for bailout stenting. What I failed to mention with standard balloon angioplasty is the industry folks are creating balloons that go to 30 and 40 atmospheres because it takes so much pressure to dilate these calcified vessels. Lithotripsy allows you to get the vessel open at very low pressures, 2 to 6 atmospheres, reducing your chances of barotrauma. Because there's in situ plaque fracture, there's no reported significant incidence of distal emboli, so you don't need a filter, you don't need distal embolic protection. The balloon is a little bulkier than a standard angioplasty balloon, so in the tightest lesions, you may need to do a small balloon predilation. So here's an example. This is a case that Dr. George Adams shared. where there's significant tibio-perineal trunk and posterior tibial disease. So here's a balloon across the ostium of the posterior tibial and perineal arteries, brought back to treat the tibio-perineal trunk. And then there's a tight lesion at the ostium of the perineal artery. And the final result is excellent. And that was standalone intravascular lithotripsy. They have done a study, it was very small, called Disrupt BTK. In that study, 21 lesions total, there was no incidence of dissection, embolization, or acute significant complications. The residual stenosis following lithotripsy alone was 26% with an acute gain of 1.5 millimeters. Very short-term follow-up showed 100% freedom from target lesion revascularization. The next modality I want to discuss is plaque debulking or modification. This is mechanical debulking of the plaques. So under the mechanical category, we have orbital, rotational, and directional. I'm going to go over each of these. And then photoablative is excimer laser. I'm not going to spend any time on directional atherectomy with this talk. This has been used below the knee, primarily in large popliteal vessels or very large proximal tibial vessels. So I'm going to focus on orbital and rotational atherectomy and excimer laser. So orbital atherectomy uses a technique called differential sanding. It wobbles around an orbit so that it differentially sands plaque while not disturbing healthy tissue. It does come in different shapes and sizes of the crowns, depending on what type of lesion that you're treating. They have smaller ones, larger ones. They have a proprietary wire, so you can't just put this over any wire. You have to use the wire that comes with the device. And so this is a nice option below the knee and in tibial vessels. One study that they've done so far is called Calcium 360, about 30 lesions in each arm. The treatment arm was orbital atherectomy plus PTA versus PTA alone. What you see is by plaque modification, you're able to dilate the vessel at a lower pressure, 5.9 atmospheres versus 9.4. The freedom from revascularization was higher, and the freedom from major adverse events was also higher with atherectomy, followed by PTA versus PTA alone. Rotational atherectomy is a similar concept, but it rotates around the wire. Rotablator, which is used in the coronary space, it's a similar device. There's a peripheral rotablator. It has a front cutting burr. They also have a proprietary wire. A couple of other devices are Jetstream or Phoenix, but typically, again, those are reserved for larger popliteal arteries or very large proximal tibial vessels. The panels on the right, you can see that there's diffuse disease in a posterior tibial artery. That's the artery on the far right in each panel. And you can see after rotational atherectomy, there's an excellent luminal gain and a nice angiographic result. The last category under plaque modification is excimer laser. This uses a high energy light beam to vaporize the plaque. There is a large generator currently, which is required. One advantage is this can be used over any 014 wire that's non-jacketed. So you can put it over any 014 workhorse wire that you like. There was a trial called LACI, which is laser angioplasty for critical limb ischemia, 145 patients with 423 lesions. In this group, 41% of that group were infrapopliteal lesions. The procedural success rate was 86%, and the limb salvage rate was 92% at 6 months. And on the right, you see a vessel treated with laser atherectomy with a very nice luminal result. So I showed you several ways to prep the vessel with atherectomy or scoring balloons, cutting balloons. So does this actually improve patency? The XLPAD registry was a retrospective data collection covering 10 years and almost 2,000 patients. In this percent of the patients had atherectomy, and what you see in the graph to the right is event-free probability, and the event was 12-month repeat revascularization. So there was a significant decrease in repeat revascularization procedures when atherectomy was used as the initial treatment versus balloon angioplasty alone. So question is, I showed you guidelines from 2014. In 2020, is PTA still the standard of care for below the knee intervention? For non-calcified disease, you could argue that probably that's still a reasonable initial strategy. But for calcified disease, probably not. We have several devices which allow us to modify the plaque, modify the vessel. And there's been, since that time, some of the studies are small, but we do have data suggesting that improved outcomes with vessel prep. The disruptive debulking therapies have been shown to have a greater acute luminal gain versus balloon angioplasty, although there is an increased cost. But if you can decrease future revascularization procedures, it may balance out. Doing disruptive and debulking therapies may result in greater long-term patency and require less reintervention. The devices all have their specific learning curves and particular complications, which you need to be aware of and understand. So when you're working in the below the knee space, recommendations that I have, I would get very familiar, very comfortable with at least a couple of these modalities in each category. Be comfortable with an atherectomy device, be comfortable with intravascular lithotripsy or cutting and scoring balloons. There are plenty of courses out there that the industry folks can tell you about. Meetings such as NCVH, Viva, other meetings. You can go to presentations using all of these devices, and then ask questions. When you're at meetings, go up to people that are doing this every day. Go to the people who are doing the talks, leading the meetings, leading the courses, and get their input. But this is an incredibly important space. I think this is something that you can learn to do, and I encourage you to look into that further. So this concludes the presentation. I really appreciate the opportunity to share this with you. Thank you again to Dr. Walker, and that's it.